Good afternoon, everybody. What I have to talk today is 3/4 has been covered by Dr. Sangeeta. So you will find little overlap of slides and probably I'll try to skip most of it. At the outset, my sincere thanks to people who had promised to be here, and I'm thankful to almost 30 people who are already here. And to become volunteers, and as you say, the volunteer is actually totally voluntary. And as Dr. Sangeeta had just pointed out, that it's a shame for our country that our maternal mortality is still high, very high. And something has to be done by the medical fraternity, and as well as political will has to be there to do that. We can definitely make a bit, because Millennium Development Goal 5 is something which is achievable, and probably we should try to do that. Now, whenever you see Taj Mahal, it always reminds you Death of the Queen. When everything, this shows that, you know, the money cannot save life. This face also reminds you that the gynecologists that they could not save the life of Smita during her delivery. And this maternal death clock by the UNICEF shows that one woman dies from pregnancy-related complication every 5 minutes in 2012 December in this particular country. This is underestimation, as just now Dr. Sangeeta has told you, that the figures by the UNICEF and the WHO is still around 300 to 400 per 100,000. Now, you can see here the iceberg, the tip of the iceberg, which is a maternal mortality. For every maternal mortality which happens, there are minimum 5 cases but nearly died, but they could be saved. And there are another 15 cases. As a process of delivery, they become moribund and they take long time to recoup. This is what I just now said about the near-miss cases, that this is a good parameter of the health of the woman in the country. And this speaks that a woman who nearly died, but they could survive the complication which occurred as a result of pregnancy, delivery, or in a postnatal period. Dr. Sangeeta just now mentioned about you is our Millennium Development India has committed in 1990 that 25 years down the line, that is 2015, the maternal mortality rate will be brought to 75% what it existed in 1990, and that puts a goal at 109 per lakh in 2015. And then you can see here the record, 75 years back, 20 women were dying out of 1,000 deliveries. And in 2009, 2 women are still dying per 1,000 deliveries. And we have to make it 1. And which seems that it is doable, provided we contribute our bit to this. As now Sangeeta just now mentioned, that 3 states, Kerala, Tamil Nadu, and Maharashtra, have already made it. They are below this 109, which was critical. Another 5 are close to it, provided there is a political will and the medical fraternity joins the hands together. It is really a doable goal. Millennium Development Goal 4 is decreasing the infant mortality rate. We are far away from it. But since the time this institutional delivery came, it looks like that the Millennium Development Goal 5 is one thing which India can achieve. Again, duplicating what Dr. Sangeeta had said, what do the women die of? they die of a simple obstetrical complications that need not be fatal. Simple. Obstetrical complication, as you all know about it, that the 15% of the patients during pregnancy will have obstetrical complications. And 5% will be life-threatening. And this is all world over. Whether she delivers in Bangladesh, she delivers in India, or she delivers in US, the picture remains same, and nobody knows why this particular fact of life is universal. Most obstetrical complications can neither be predicted nor prevented, but if a woman receives timely, effective treatment, almost everybody can be saved. Can we look at the face and predict? We cannot. So, the spirit of every gynecologist should be that we make every mother and child count. In 2012, every minute, 400 conceptions are taking place the world over. And the tragedy is half of them are unwanted, unplanned. And out of that, nearly 1/4 will develop complications. So ensure that every pregnancy is wanted, and that will come only by the usage of contraception. In this country, what is happening, everybody knows whenever the surveys are done, the knowledge of Indian men and women about contraception is great, but when it comes to usage, there's always a withdrawal method, as if they're trying to do something very great. And I always tell them it was so great that it had been mentioned. Why should the governments after governments and very medical farmers will be spending that kind of money? Now, this is, WHO has come out with, for everything, direct complications are 80%, indirect complications are 20%. For every complication which you can see, there is evidence-based interventions. If they're done timely, we can definitely save the patients. Now, as far as the abortion deaths are concerned, as you all know, that hemorrhage still takes about 24%, abortions and eclampsia makes another 25% put together, infections make another 13-14%, and obstructed labor makes about 8%. As for the abortion deaths are concerned, which makes around 13%, we have to see to it that every abortion is made safe. And that's possible by comprehensive abortion care, which really does not require much. We know that medical abortion and vacuum aspiration are the safest method. If they're safest in the United States of America, then why not here? The simple thing, manual vacuum aspiration, which does not even require electricity, can definitely do a wonderful job in a low-resource setting like India. As far as the death is concerned, there are 3 critical factors. The first is the time. I'll get back to this. Already Dr. Sangeeta has pointed about this. And secondly is the concept of 3 delays. And thirdly, 3 points. Which access to care is delayed or denied, or there is a total lack of care, then it will definitely lead to maternal death. Time, what just now Sangeeta said, again to remind you again, when it comes to postpartum hemorrhage, if intervention has to be done, if she has to be treated, it has to be the first 2 hours. For an antepartum hemorrhage, it remains 12 hours. For obstructed labor, it is 2 days. And for infection, it is 6 days to make the difference between life and death of that particular woman. Thanks to the government of India that they agreed to one thing when we people pleaded that there should not be any home delivery. This Gender Suraksha Yojana came in a very big way. The essence of this particular thing is the emphasis is on institutional delivery away from home. And secondly, a proper referral system should be made from primary health center to CHC to district level, where the facilities are available. Now, creating awareness has to be done by doctors. It has to be done by nurses and various self-help groups to create awareness that if she has a home delivery, she puts her life and her child to the risk. And good enough, 9 months' time is good enough time to create this kind of an awareness. Now, planning which goes at home level has to be threefold. Who is going to deliver me? Who is going to be the skilled attendant? And what is going to be the place of birth? Is it difficult? It is not difficult. And then what will be the support people I need to take care of my home when I'm away for delivery? In Janani Suraksha Yojana, the whatever infrastructure is available, there are 4 I's. We have to inform that what is your expected date of delivery. We have to inform what is the days of the ANC when she has to touch the sub-center or primary health center. We have to identify a place of delivery for her, and we have to really identify and tell her which is the health center if case her pregnancy is complicated or if she has a previous cesarean section that she has to go. Just now, Dr. Sangeeta mentioned again about the delays. The first delay is at home. And I think if we involve the male, that if your wife is dear to you and if your child is dear to you, you have to get involved into it. And I just now said that the family has to do away with the traditional practices of delivering at home, and all that lack of money, everything can be sorted out if the gentleman is motivated. And if you just tell him the risk of life to her wife and the child. We all know the terrain of our country, but in case if you want to really access, we can definitely do that. Wherever you find that emergency obstetrical care has to be made available, as just now I said, that out of the 15% people who have complications, in 5% of cases it can be life-threatening. At that particular time, few minutes also matter, and we should have a proper referral emergency system. There's a toll-free number 108 you'll find wherever either the government vans are there or public-private partnership is there. It is 108 which has to be dialed for you to avail these kind of services. The helpline again, you can see. The worst part is the third delay. The person arrives at the health service center and still the woman dies. And this can happen that either we are not motivated, we are not skilled, we do not have the equipment or supplies, the reference system is not working, but we fail to prioritize. We fail to prioritize what is emergency and what is non-emergency. I lost my mother in the medical college 3 hours after reaching the place. This is what happens day in, day out. For this, addressing this third delay, you people are all here to see to it that you are geared up to emergency obstetrical care. It should be in your system that you don't have to exert your mind what has to be done what. In emergency obstetrical care, you require 4 things and 4 skills. The things are antibiotics, the set of oxytocics, anticonvulsants for eclampsia, and ready availability of blood transfusion. The skills are manual removal of placenta, removal of retained products of conception and abortions, assisted vaginal delivery, and cesarean section if needed. What is the good news? The good news is not all these functions need hospitals and doctors. Well-trained nurses and midwives can perform most functions at a basic emergency obstetrical services facilities. You've seen in UK, you've seen in Middle East. 85% deliveries in UK are done by nurses.
These 85% not even once make a visit to the doctor. I have known cardiologists, I have known senior people in the medical profession, and the wives had not made a single visit to the doctor. Same happens in Middle East. 85% of deliveries are done by the sisters. And that is why we feel, and the biggest resistance in this country had been why nurses cannot practice are the doctors, doctor community. The difficulty now it has been passed that the nurses can also practice. So what is important is that we, in a resource poor setting like India, we should definitely take a tip from these developed places that as far as the emergency obstetrical services are concerned. Making emergency obstetrical services functional. 700 gynecologists in this country who are in a government job cannot take care of all the deliveries which take place in this country. So you have no other choice but to hire private anesthetists and private gynecologists. And the states which have followed this up, as you can see in Gujarat, you can see in Madhya Pradesh things are happening. You can find that quite a significant number of deliveries have been taken up by them. And I think more and more centers or more and more states have to really urge the gynecologists and anesthetists to take up this. And the second option is that you train MBBS doctors to give anesthesia or to perform cesarean section. Because if it can be done in the United States of America, a person who does hospital, family medicine practice, they take a specialty. That they have a specialty of doing a cesarean section. Somebody takes a specialty in neonatology, somebody takes in any other things. So you can have, this can be a special thing which you are allowed to do. And I think of that kind of things we should also be trying to work on these lines. This is public-private partnership, again same 108, to pick up the things. Two things can happen. Either we can pick up a person and transport to a place where facilities are available, or this mobile van has everything. The means and the man who is skilled to take to that particular place, but I think the other way round will be definitely better. And then coming to our force, the life skill drills. These are very, very important, and nurses and doctors should be geared up to do what has to be done. Enforcing accountability in the medical and nursing profession is very, very vital in case if you want to put a stop to maternal deaths. And then the government has to come readily to cover up this indemnity scheme, to cover up the various professionals who are dedicated in case if some mishap happens, so they are covered fully. So the countdown begins. We are entering 2013 now. We have just 2 years to go, and we can definitely see that NGF5 goal is something which is doable. All you can see, it requires training on a war footing as far as ASHAs are concerned, upgrading of PHCs, equipments, and 24 hours emergency available. As you all know, anemia is something we should be, again, fighting it out. By the time a girl reaches 12 years, her hemoglobin should be definitely 12 grams %. We should have standardized countrywide protocol as far as the PPH is concerned, eclampsia, severe anemia, and regular drills. You'll be appalled to know that still, if there are 35 doctors sitting here, when it comes to eclampsia regime, in spite of knowing standardization, still we are far away from that. And I think a couple of drills which happened today, we have to follow it in total. PPH is the #1 cause. It requires oxytocin, it requires blood transfusions, and it requires a very simple thing which I think will be taken in detail. Eclampsia drill will be again covered up beautifully today. And a word about, again, hemoglobin and the IQ of a child. I feel each one of us should be very serious about it. The lady must be told, if you want IQ of your child equal to Abdul Kalam, then your hemoglobin has to be 1340. And if you want your process to be made, you can do anything what you like. And I'm sure after that, this particular sentence, she'll be very serious about things. Community involvement is very important. Not only community involvement has to be done to that extent that the primary health center, the community has to see that it is welcoming as far as the outside and inside things of primary health center is concerned. Again, every pregnancy has to be tracked, as happens in Gujarat. If it can happen in Gujarat, then why not other places? Every maternal death has to be audited. And as the Foxes says, that this woman should be nirogi, nirbhay, nischint, nari honi chahiye. We all know about where is this thing. Now coming to what should be my role. There has to be only will and will and will. You should be willing to step out of your door that yes, I'm going to make a difference in the life. What to change and why to change has been already rubbed by Dr. Sangeeta and myself. As for the skill is concerned, I think all of you know. Whatever you have, whatever you can, wherever you are, you have enough material to make a difference. I can only say, I may not have gone where I intended to be, but where God willed me to be there, I am definitely there. Every maternal death make a hell of a difference if the mother is alive or not. And I think, let's come together and write a new future for saving a mother in India. We can do it with willpower and hard work to respect Indian women's life. Thank you very much.